teachers like you are a rare find nowadays. Your teachings motivate and inspire us. Thank you, sir.
Thank you, Dr. Kale. I'm Dr. Prashant, welcoming you to this webinar on behalf of HITRO, webinar on difficult to treat autoimmune disease. HITRO, we know, is an innovative pharmaceutical company marketing products in multiple therapy areas. Besides dermatology, we market products in ortho, respiratory, and women's health, and so on. We have very strong R&D, and we have developed products based on patients' need. We market NSAID patches to improve patient compliance and ultimately treatment outcomes. During COVID times, we are marketing favipiravir, remdesivir for patient benefit. We also market luliconazole lotion, a unique formulation with a film-forming technology to improve patient outcomes. Today, I have the pleasure of inviting moderator for today's meeting, senior dermatologist Dr. Saple. It is more pleasure because Dr. Saple happens to be my teacher since 1974. When I was in JJ, when we were crawling, Dr. Saple was holding our hands and making us walk. Sir, happy Teachers' Day.
Okay, thank you, thank you.
Dr. Saple needs no introduction. He's MD, FCPS, honorary professor and head of dermatology, venereology, leprology, retired from JJ Hospital and Grand Medical College. Dr. Saple is consultant in dermatology, venereology in SL Raheja Hospital and Bridge Candy Hospital, Mumbai. Trainer for fellow program in HIV/AIDS, IDVL, ex-president IDVL Maharashtra branch, member of IDVL SIG for dermatophytosis since 2 years. Sir is ex-president College of Physicians and Surgeons, Mumbai. Dr. Saple has delivered 1,170 lectures across country and represented the country at over 108 international events. Sir is editorial board member, IDVL Textbook of Dermatology. Dr. Saple has 45 plus peer-reviewed publications and chapters in medical textbooks, 55 plus papers presented in international conferences. Dr. Saple has also organized national conferences on STD and AIDS, 1998, HIV and AIDS therapy, 2007, 2009, 2011, 13, and 15. International collaboration in academic research with Harvard School of Public Health, Johns Hopkins University, University of Yale, University of Toyama and Osaka, University of KwaZulu-Natal, and University of Roma, amongst a few. Dr. Saple has received Lifetime Achievement Award conferred by Indian Medical Association in 2017, Mumbai, Lifetime Achievement Award conferred by Indian Association of Dermatologists, Venerologists, and Leprologists in 2018, Maharashtra. Dr. Saple's Best Practitioner Award at Dermacon International Conference 2019 held at Bangalore. Recently, Dr. Saple has published an article, an open-label single-arm pilot study to evaluate safety and efficacy tolerability of daily fluconazole 150 in patients suffering from tinea. Sir has special interest in psoriasis, atopic dermatitis, and urticaria. I also welcome other panelists, Dr. Kale and Dr. Snehal, when she joins. Over to you, sir, and once again wishing you a very happy Teachers' Day.
Okay, thank you, Prashant, and thank you, HITRO Healthcare, for such a nice introduction. Can I share my slides?
Yes, sir.
Yeah.
Yes.
एक मिनट Hello, can you hear me?
Yes, sir.
Yeah, good evening. And today being at the Teachers' Day, everybody feel that teacher should give some message.
Yes.
But I feel in other way that all of us, we are teacher for each other, because always we learn from each other. So I wish best of luck for everybody on the Teachers' Day and a happy Teachers' Day. Today we are going to discuss about use of immunosuppressive therapies in various dermatoses. And we have got panelists, Dr. Govind Kale, I'll be moderator. Another panelist is Dr. Snehal Lunge-Patil, So these are the two panelists. We are going to discuss what are the various conditions we can use immunosuppressive drugs. Dr. Kale, he is from Aurangabad and he has got very good experience for last 28 years. I know him. He's a hardcore clinician and dedicated to patient. Of course, he has got the honor of organizing Mid Dharmacon in 2014. So we'll have Dr. Kale from Aurangabad. Another panelist is Dr. Snehal. She is MD Dermatology, Venereology and Leprology, Associate Professor in the Department of Dermatology, Consultant Dermatologist at Bharatiya Hospital and Research Center, Pune. So we have got very good combination. One experienced doctor and another is upcoming doctor. So this will be the best combination according to me. So we'll, I think, start with our topic or subject that Dr. Kale, first I'll ask you only, what are the immunosuppressive drug you're using in your practice?
Sir, I use methotrexate, cyclosporine mainly. Nowadays, tofacitinib.
What are the other drugs? Tofacitinib, cyclosporine,
Mycophenol, mofetil.
yeah, whatever the drug you're using in your practice.
Mainly methotrexate, cyclosporine,
Yeah,
tacrolimus,
yeah,
and nowadays tofacitinib.
yeah. The tacrolimus usually is the only local.
Local.
Dermatologists, we are not using systemic, that is used in the organ transplant. So
Yes.
we'll have corticosteroids. Now you're forgetting because you've got so many immunosuppressive drugs. But that is our basic drug. Systemic corticosteroid, methotrexate, cyclosporine, azathioprine, cyclophosphamide, mycophenolate, and now biological. So many are there. But today we're going to discuss the novel drug that is tofacitinib, because it's not possible to discuss each and every drug. And when you're talking about tofacitinib, we are going to discuss our Indian clinical experience more than theoretical possibilities. So I'll start with Dr. Kale again. What about Dr. Snehal? She has joined or no? Giridhar? Anyway,
Sir,
till she joins, we'll carry on. Yeah.
okay.
So, Dr. Kale, of course, I'll just give what is it? Tofacitinib is a transducer and activator of transcription. Secondly, is an intracellular signaling pathway upon which many different pro-inflammatory signaling pathways converge. And most of the inflammatory dermatosis, they depends upon this intracellular signaling pathway. And if we can inhibit the JAK inhibitor or intracellular signaling pathway, we should be able to treat inflammatory dermatosis. That is the rationale behind it. So, one second, I'm just adjusting my, yeah. So what is JAK inhibitors? JAK inhibitor is one of the immunomodulator medication which inhibits the activity of one or more of the Janus kinase family of the enzymes. That may be JAK1, JAK2, and so. And therefore interfering with JAK-STAT signaling pathway. So it blocks JAK and interfering the signaling pathway in the lymphocytes. That is the action of the JAK inhibitors, or what you're going to use is tofacitinib. So what is the action? For example, for any process, when there is the signaling to cytokines and the antigens and the cytokines, they combine together. There is an activation of the JAK, or what is called phosphorylation. And the JAK phosphorylation get attached to the STAT, and further phosphorylation or activation, they form a dimer. They combine together and they get translocated in the nucleus and start transcription and producing cytokines. And more cytokines, more inflammation. So if you block the JAK or we use JAK inhibitors, there is no intracellular signaling. If there is no intracellular signaling, there is no JAK stat, there is no dimer, there is no translocation, and there is no production of cytokines. That's how the JAK inhibitor tofacitinib works. So what are these various JAK inhibitors? Tofacitinib, ruxolitinib, baricitinib, which is used in COVID-19, ruxolitinib, there are many. And now we got tofacitinib. So, Dr. Kale, what are the indications you are using tofacitinib? Dr. Kale, can you hear me? Manohar,
Yeah, yes, sir.
can you hear me?
Mainly in alopecia areata,
Yeah,
vitiligo,
yes,
then psoriasis,
yes,
prurigo nodularis,
yes.
and
Yeah.
so many indications, but I have not used hidradenitis suppurativa, lichen planus.
Yes, correct. Yeah. Yeah, as Dr. Kale has said, mostly it is used in atopic dermatitis, alopecia areata, psoriasis, and vitiligo. But there are, as Dr. Kale has mentioned, there are other indications where we can use like a dermatomyositis, chronic actinic dermatitis, erythema multiforme, lupus erythematosus. There are many conditions can be used. There are smaller studies and there are some anecdotal examples in B-cell mediated disorder, pyoderma gangrenosum, eosinophil related disorders, allergic contact dermatitis. There are many indications, but those are called off-label indications because they are not enough evidences means clinical trial. So there are various indications. According to me, we are going to discuss and show the cases that will give us idea. So Dr. Kale will starting with the first case. Is a 45 years old male patient who has chronic plaque psoriasis suffering from 5 years. You can see the plaque psoriasis, very typical case, but he has got a comorbidity of diabetes, blood pressure, and he has undergone, blood pressure, and he is on multiple drugs. So, of course, he has taken the topical application, steroid salicylic acid, but there was no improvement. And when he came to our clinic, we started cyclosporine because that is one of the very effective drug. But after some time, his creatine started rising and his blood pressure also started rising. So, Dr. Kale, how you are going to manage this patient in your clinic?
So if his LFTs are normal, we can start with methotrexate.
Okay, one second. So Dr. Kale, we follow your advice, started with the methotrexate. But when you started with the methotrexate, patient developed leukocytopenia, hematological toxicity. Now, what you will do there?
Even acitretin can be started if the lipid profile and other things are
Yes,
normal.
correct. Yeah, but he had a dyslipidemia. Of course, there is no other option we can start. But he had a dyslipidemia. Then what is the other option? Of course, then we started this patient. This is exactly 4.5 years before we started this patient.
So
tofacitinib, 5 milligram BID. Of course, after this thorough evaluation, after basic test, and I was surprised to see that after 1 month, everything was clear. But the question comes, whenever the patient of psoriasis, they come, they want a quick result. And we know cyclosporine is very fast results because that is well known. But then we wanted to know whether tofacitinib can do the same effect or not. So this is another patient. If you see, we started tofacitinib as a rescue therapy, and after 2 weeks, see, erythema is gone, scaling has subsided. See, even on the elbows, and patient was very happy. So you can use tofacitinib as also for the quick relief, or what you call, if they want fast relief, it can be used, or what we call is the rescue therapy.
Rescue.
Doctor,
Okay, sir.
yeah, Dr. Kale, you want to add anything on that?
No, that
No,
If-
okay, then we'll go for the next patient.
because one rescue drug, our cyclosporine is failed. So
Yeah.
this tofa is a very good alternative, and within a small span of time, in 2 to 4 weeks, where if we are getting result, that is very well. So good.
Yeah, I entirely agree with you, Dr. Kale. This is one of the good option. And as when the patient has got hypertension, he has got diabetes, comorbidity,
Home.
like a steroid, cyclosporine, they become difficult to use it because the comorbidity. And of course, methotrexate is a good drug, but the patient had hematopoietic side effects. So we have no choice. And as Dr. Kale said, acetradine is also a good drug, but it takes longer time. It takes almost 1 month to 6 weeks to be effective. And of course, the patient had dyslipidemia. Dr. Kale, now we have got another patient. This is a patient of pustular psoriasis, but again, she has got diabetes and hypertension.
Okay.
And we treated this patient with systemic steroid about 40 milligram. She was admitted, antibiotic, and was discharged with 40 milligram of oral prednisolone.
Sir, which antibiotic has given?
Pardon?
Which antibiotic is given?
This patient, augmentin was given.
Augment. Okay.
Yeah. Oh, it's good thing, Snehal, you have joined. Very good.
Yes.
Now,
yes,
I think you
I
should
want to
answer.
add
Yeah.
few things. Okay, sir.
So-
We'll discuss now.
Yeah, now you should do what we should do with this patient.
Sir, first of all, I want to do little bedside investigations, like
Yes.
the pustules are sterile or not.
Yes.
I do gram stain,
Yeah.
and I want to do a skin biopsy to rule out
Yeah.
pustular psoriasis from acute exanthematous dermatitis reactions.
Yes.
And we can start patient on systemic methotrexate.
Hmm.
If patient is not responding to systemic methotrexate, then cyclosporine is another option.
Yes. Hmm.
And if cyclosporine also doesn't work, then the cheapest drugs, if G6PD deficiency will be not there, if
Mhm.
patients are ready to do G6PD levels, then
Mhm.
Dapsone will be the drug of choice, sir, for such kind of patients like pustular psoriasis. What I have treated in my clinical practice.
Yeah. So, Snehal, I'm very happy you started with the basic thing.
Yes, sir.
Yeah, that first you have to confirm is really pustular psoriasis or
Yes, sir.
something
That
else.
is the main thing. Yes,
So
because
I was very
government
happy
patient
you
has
got the
received.
culture sensitivity done.
Yes, sir. Yes,
We
sir.
have to do that and the biopsy. We do this
Yes, sir. Yes, sir.
routinely and then confirm. Once we confirm,
Yes, sir.
agree there are many options, but methotrexate also, it takes little bit longer time.
Longer time. Yes, sir.
Yeah. Secondly, Dapsone, so it takes very long time. But
Yes.
these are the drugs I use it for the maintenance therapy. For the
Okay.
maintenance therapy, of course, cyclosporine is a good drug.
Yes, sir.
Patient is diabetic, hypertensive.
Hypertensive.
Yeah,
Yes.
how long will continue?
Mm.
And of course, pesulimab is now available.
Yes, sir.
Of course, in the extended clinical trial, and is very expensive, and you are waiting. That is one of the very effective drugs. But as these drugs are not available, we were going ahead with the steroid. But how long will continue steroid? So what I did, I started tapering steroid and introduced tofacitinib.
Tofacitinib.
Yeah, and of course monitoring and proper evaluation. And see, at the end of 45 months, that is almost 4 years, there is no relapse, there is no flare up, and this patient is 62 years old
Okay.
and she is doing very well. I thought I'll share this experience.
Yes.
So, Snehal, you want to add something in this?
Sir, I just have one query. As patient is already diabetic, so there's
Yes.
no drug interaction with the anti-diabetic and antihypertensive drug in this patient with tofacitinib. That is my first query. And my
Yes.
second query is how you have monitored, because diabetes is also prone for many opportunistic infection. When
Yes,
we put a patient of tofacitinib, I have seen many patients of mine rheumatoid arthritis, they develop herpes zoster
yes,
or
right.
current folliculitis or furunculosis. So how is
Yes, correct.
the complication in this patient of 45 months duration?
Yes, correct.
Yes.
See, yeah, Snehal, you have opened up very good question.
Yes, sir.
See, I'm dealing with this tofacitinib for last 5 years.
Yes, sir.
And almost I got 500 patients on tofacitinib and I'm following them. As you said, herpes zoster is one of the things you have seen, but I
Yes.
have seen only that topic is coming. I'm going to show that patient, but herpes zoster, I have seen only 3 cases. And
Okay.
this herpes zoster is not severe. I'm going to show the picture. I
Okay.
think that time we'll talk, but it is usually the mild attack. And the mild attack, you can continue tofacitinib, but now we are talking about the rheumatologists. Rheumatologists are using 3 drugs: SCQS, methotrexate, and tofacitinib.
Tofacitinib.
Yeah, all 3 drugs they are using it because I'm discussing with them for last 5 years. So
Okay.
they are immunosuppressed because methotrexate, tofacitinib together.
Okay.
And most of their patients, they develop herpes zoster after 3 years, 4 years of combination, not before that. So
Okay.
first 1 or 2 years, you will get hardly, as I have seen only 3 cases. Of
Okay.
course, many patients are tofacitinib, but my tofacitinib, when we tapered, for example, this patient, we are giving 5 milligram once in a week, where
Okay.
there is hardly any immunosuppression. And I'm happy you have discussed with the rheumatologist and their findings because they are using combination of drugs where they are more immunosuppression. And secondly, they are seeing this immunosuppression after 3 or 4 years. But as you said, folliculitis or fungal infection, that we see within 2 to 3 months. I entirely agree with you. Yeah.
That is there, sir, because many of my patients have landed with another things when they have
Yes,
a
correct.
severe 10 years or 20 years of diabetes history. They'll
Yes.
definitely get tofacitinib is very good drug. I'm very happy with
Yeah,
the
and there
result. But
yeah,
the only thing is infections.
hardly any drug interaction
Hardly
because
any drug
it is not
interaction.
metabolized
Safely
by
start.
CYP3A4,
Yes, sir.
which is have lot of drug interaction.
Sir,
Okay?
sir,
Yeah,
one second. I agree with you. Whatever
yeah,
my little experience, I
yeah.
have also not seen herpes zoster. Though they say, and whatever your expression, that is a real truth, because we may be using a less dose, 5 milligram BD or what.
Yes.
That's why we are, though books mention whatever 50, 60 cases, I have not seen herpes zoster as such.
Yeah,
Yeah.
in 2 patients of rheumatoid arthritis, one is on italizumab, methotrexate, and tofacitinib, and
Yeah, that,
on MMF, leflunomide, and methotrexate, and HCQS. So
Yes.
both are rheumatoid arthritis patient with tofacitinib. Yes, there are many drugs, but only one patient I have seen she has cardiac bypass surgery. So she has is on blood thinners like ecosprin,
Yeah, she has got multi
plus
complications.
hypertension, and plus tofacitinib I have given her for psoriatic lesions.
Yeah.
She was very well maintained because she was a side effect from apremilast. She got side effect from methotrexate.
Yes, correct.
Cyclosporin is not an option because cardiac events means she is already hypertensive. So there tofacitinib is good, but she got herpes zoster after starting tofacitinib of 3 months of duration. So
Yes.
I am not understanding ki whether it's because of tofacitinib is the only
What was the
immunosuppressant
age?
was
What
going.
was the age of the patient?
Her age was 70, she was 75 plus.
Above 7, correct.
Yes, sir, she was
See,
70
above
plus.
70,
Age.
immunosuppression is more.
Yes,
And
sir.
as it is, the patient, elderly patient, they are likely get to the herpes zoster. And
Yes, sir.
that's why I convinced GSK about 4 years before that we must have Shingrix.
Yes, sir.
Actually, the patient can afford, we can give Shingrix as a preventive. Yeah.
Sir, my another question is when to stop tofacitinib and how to give Shingrix. Means after herpes zoster, you have to give a 1 month gap of Shingrix. So within how much duration of stopping tofacitinib you can give Shingrix?
Ideally, yeah, you say, as you said, it has to be minimum for 6 weeks.
6 weeks.
Because when you give any vaccine, the immunity has to be developed.
Yes,
So
sir.
if you're using immunosuppressive drug, you're not allowing immunity to develop.
Yes, sir.
So it has to be in advance. But then, as you said, you can stop tofacitinib for 2 weeks after giving any vaccine which is not a live vaccine.
Right, yes, sir.
Okay?
Okay, thank you, sir.
Yeah. Okay. It's good. Very good.
Thank you, sir.
Dr. Kale, now I'm coming to you. And of course, these are the study 339, the world literature is there that psoriasis we can use, psoriasis we can use, and they say 75% improvement in psoriasis area and severity. And this is one of the very good effective drug in psoriasis when there are other options are not there. Of course, these are the studies shows if the doses are bigger, then the results are better, and it can be compared with etanercept. It is non-inferior to etanercept or biologicals. Now, of course, we have got the local application, topical application. We'll go for the next patient. This is another patient of atopic dermatitis, again with a comorbidity. He has gone under angioplasty. Of course, but there was no diabetes, hypertension. Again, we start cyclosporine. As usual, we started getting this side effects, that is increasing the blood pressure and creatinine. We started on methotrexate, but there was methotrexate, but there was hematological toxicity. And as Dr. Kale said, acetatin, but developed dyslipidemia. Started adalimumab. And after adalimumab, he said there was a relapse. Then the patient was fed up. He came to me from Lucknow, I remember. Then we started on this patient on tofacitinib. He was doing very well. After 1 month, he said, Doctor, I'm very well, but I'm getting body ache, muscle ache, and now I'm worried. So, Dr. Kale, what do you think?
These are the transient side effects.
Yes.
Either you can lower the dose for a few days or convince patient,
Yes.
and you can restart. I think muscle ache and myalgia, these are the not major side effect as such.
Yes, I agree. Now I'll go to Snehal. Snehal, what do you think?
So same transient side effects, myalgia, secondary to tofacitinib, I thought.
Yes, correct. So, I was also naive in managing. This is almost 5 years before. So I spoke to rheumatologists. Because rheumatology have started using this drug quite early compared to dermatology. I'm using for last. So when I spoke to rheumatologists, they said, sir, it's like taking rifampicin in leprosy. What happened? They get flu-like syndrome.
Okay.
So in tofacitinib also they get flu-like syndrome. Don't worry. And as Dr. Kale said, you can continue same dose or you can lower the dose. But then for safer side, I got these 2 tests done, CPK and serum
CPK.
aldosterone. Because to find out there is muscle, because that time we are theoretical, I was thinking of rhabdomyolysis, because then that is one of the side effects, no?
Oh.
Still you agree, no?
Mm-hmm.
Hello?
Yes, sir, rhabdomyolysis.
Yes.
Yeah.
Yes, sir.
So I was thinking, because I didn't have much experience.
Yes, sir.
So I was thinking of rhabdomyolysis, but the rheumatologist said, sir, it's like taking rifampicin in leprosy. And as you both of you said, these are transient side effects like a flu-like syndrome. We can continue. And as Dr. Kale said, if you want, you can reduce the dose. So
Sir, if that patient is having history of hematuria, like which is present in rhabdomyolysis, no history, no?
no.
No history of hematuria.
Nothing. And this CPK and everything was normal.
CPK was normal.
Yeah, serum aldolase. That's why we continue. I just confirm that, better to confirm. But this is the clinical experience, not to worry.
Yes, sir.
Then we treated this Pomfolix, atopic dermatitis results are quite encouraging. And there are about 91 literature studies shows this is one of the innovative drugs in management of atopic dermatitis. Now I think Snehal, I'll start with you.
Okay, sir.
Can you see the child?
Yes, sir.
So what do you think?
Sir, he is scratching his hands.
Yeah.
Uh,
Of course, she is
maybe
a girl. Yeah.
lot of itching
No, this is happening during night time. See,
night time. Yes, restless.
intractable itching, all
Yes.
the time disturbed, not able to sleep. Correct? No?
Yes, sir. Yes, sir.
And the parent, more than the child, the parents, they have lost weight, they have lost interest in life because she is suffering. So this is a case of atopic.
Atopic derm. Yeah,
Yeah,
atopic.
so this is a 6-year-old. This patient, of course, is atopic. She was on methotrexate and pulse steroid, but in spite of she was getting this, she came to my clinic. I started cyclosporin, but with cyclosporin, she developed hair growth.
Oh, cyclosporin does wonder in atopic dermatitis. But acha, female patient.
Yes, correct. You
That's
are absolutely right. Yeah, she was, see, 90% she improved 90%,
Yes.
but she developed excessive hair growth.
Okay.
And being a girl, even 6-year-old girl, I was surprised. She was so cautious about her everything. Then what to do? Then I switched to Betnesol drop. But she developed constipation and she got weight. She gained weight. You know how much weight gain? That she said, sir, my colleague, my friends, they are not recognizing me. They say, who are you? That much weight she put on. So what you'll do now?
Sir, can I give a trial of Azoran?
Azuran, but again it's a slow
that's your
acting,
brain.
but we can give, but it's a slow acting, yeah. Because this is quite severe.
Yes, sir.
Dr. Kale?
Yeah, tofacitinib can be tried, no? Because
No.
all options you have.
Yeah,
used.
exhausted, yeah.
Yeah.
So I started with tofacitinib, 4 milligram. And you see, this is the original pictures that her almost 90% of the body surface area was involved with the exfoliation, excoriation, dryness. And can you see this picture?
Yes, sir.
Yeah, how is she improved?
She improved drastically.
Yeah, she's very happy.
Yes.
I'm giving her with, of course, monitoring with the CBC for last almost 8 months. Okay. So this is one of the very good drug for atopic dermatitis.
Atopic.
Yeah. Now we'll go for the next. I think Snehal, this patient came to my clinic with alopecia totalis, started with tofacitinib. After 2 weeks, he was happy. Continued for 3 months. He was more than happy. But now the question, how long will continue tofacitinib?
How long?
That is the only problem, sir. As soon
That
as
is the problem with the.
reverses.
Sir, being an autoimmune disorder,
Yeah.
it is going to recur.
It is going to recur. That is the
And that is the main question. But I think whatever 8 to 10 months, once we achieve the result in any thing, alopecia or
Yes,
atopic,
correct.
then
Yes.
some other drug that is a less having this thing side effect or
Yeah,
even
less
cost
side effect
wise,
in uploading, correct. Yeah, so as
that
Dr.
you can maintain.
Yes, correct. As Dr. Kale said, we switch over this patient on methotrexate. Many patients will switch over to methotrexate because they need long-term treatment for 1 year,
Yes.
2 years. So slowly we switch to methotrexate, or sometimes keep on reducing dose and maintain on them 5 milligram once in a week. But it has to be 1 to 2 years. Now, these are the cases from Dr. Kale. So Dr.
Yes.
Kale would like to elaborate on this.
This is a 7-year-old child
Hmm.
already came with all treatment she has taken. Near about, you can see the 80 to 90% involvement, alopecia, near about alopecia totalis. And already dermatologist has given oral mini pulse, topical tacrolimus, topical steroid. Somebody given even excimer, lasers and all. So all options are finished.
More.
So
Yeah.
I started her on 5 milligram tofa.
Oh.
So even after 2 months, I got this result.
Okay, this
And
is
the further two photograph, I think this
yeah,
is the
these are
same
your
one.
yeah.
This is after 4 months.
Yes. Oh, such a beautiful yeah. very
So I have
beautiful.
given her total for some 7 to 8 months.
Yeah.
And now if she feels some patches are remaining, she is coming from Goa. Actually,
Huh.
she is from Hingoli.
Yeah.
So for few patches, I am advising tacrolimus topical application.
Okay.
So now till this time, she is happy. 1 or 2 patches again, she is applying tacrolimus.
Snehal, you would like to add something to this patient?
Sir, I have given contact sensitizer also in this such patients,
Mm-hmm.
along with the tofacitinib,
This
Okay.
like DNCP and DPCP.
DNCP.
Yeah, DNC.
Tried, if patient is allowed, then tried some small patches 1 by 1 centimeter, like topical latex, phenol also.
Phenol also, the
Phenol
area is huge.
And ILS is the first thing. Means if there are any patches, ILS we used to give. Topical, topical
Yeah.
corticosteroids, like mild
Because it's a
corticosteroid, or
child.
if patient allows, then injectable ILS.
Yeah, because the child is injectable is very difficult.
Yes, sir, very difficult.
Yeah,
But
then
since
yeah, but
we have given pediclor to the patient and topical application of anesthesia for 45 minutes, along with the oral anesthesia, then we can give. Like
yeah, but anyway,
to avoid
yeah,
systemic
it's
side
a
effects.
bit high. Yeah. So we can give local irritant, or you can give ILS, but
ILS.
of course it depend upon the situation. But
Yes, sir.
these are the recalcitrant patches where I have used tofacitinib topically, locally.
Locally.
Yes, correct. And that has helped. So
Yes.
we'll go for next. This is again Dr. Kale's patient. So Dr. Kale, can you?
She's a 34-year-old female.
Yeah.
She had a large patch on occiput, alopecia patch,
Mhm.
since 12 years.
Yeah.
Since 12 years.
12 years. She came from Latur,
Yeah.
visited many dermatologists.
Yes.
All things tried, oral
So
mini
it's a
pulse,
recalcitrant. Yeah.
even this thing, intralesional steroid and all.
Yeah.
We can see the small growth also. She has responded, but afterwards, she was not responding to any line of treatment.
Mhm.
So
There
then,
is trichotillomania, no?
no. That 12 years, I was
Trichotillomania or
asking,
hair loss.
in fact, trichotillomania is mainly in frontal scalp and all. She is highly educated. And this growth is
Yeah.
after few
Okay.
treatment of tacro and all. So I have started 5 milligram of tofa BD, and these are results.
And these are the improvements. See, no, this is the patient result. No.
Yes.
Very nice.
Yeah, it's a wonderful.
Wonderful.
Yeah,
After
but as Snail mentioned, one of the differential diagnosis is trichotillomania, because that is the age. Yeah, because we have to confirm, and nowadays we do dermoscopy.
Yes, sir.
Dermoscopy is a very handy, the more than doing a biopsy.
Yes.
And dermoscopy is very useful. So in my clinic, dermoscope, whenever you have suspected cases, as Snail says, first confirm the diagnosis. We do
Yeah.
dermoscopy.
Yes, sir.
Yeah, and then, but this was a case of alopecia areata. She has responded very well.
Yes,
But
sir.
one of the differential, I agree. So these were the cases of Dr. Kale, and
Yes.
there are 254 study where they say this. tofacitinib is one of the very good drug in managing alopecia areata. Of course, there are topical talking. Yeah, this is another patient, Dr. Kale. This patient is 75 years old lady.
Yes.
She came to my clinic. She said, "Sir, I want hair. Now, what we can do to this? But I'll give a history. This is 75 years old lady, known diabetes, hypothyroidism, hypertension, hemoglobin in 7.2 gram, and she has a non-secretary loss of hair over the scalp and eyebrows. And dermoscopy we did shows dots and empty follicles.
Empty follicles, yellow dots.
Yeah. Yeah. So, Snehal, you want to take up this patient?
Yes, sir.
Yeah.
So wanted to start her on by seeing oral corticosteroids, oral mini pulse therapy was my first option.
No, she has diabetes.
But she has diabetes. Then
Yeah,
Diabetes.
more than that. Yeah, no, you're right. But more than that, I should have mentioned. She said, I don't want to take any internal medicine.
Any internal medicine.
Yes.
Then topical, sir, contact sensitizer will be the best thing. DNCB, DPCB.
Yes. Yeah. Okay. Yeah.
And then
Yes.
88% phenol partially. Along with she can go for turban PUA, Excimer.
Okay.
And
Exactly.
topical, of course, topical tofacitinib.
Yeah. First thing, she's 75 years old lady. Her hemoglobin wants 7.2 gram.
Yes, sir.
So we say
Correction.
we thought because of the aging process, hemoglobin is less. So what he did, we did a biopsy, as you said, we have
Yes,
to
sir.
confirm the diagnosis, but biopsy shows alopecia areata.
Oh.
So when he
So
said,
they have typical swarm of bees appearance around the hair bulb.
yes,
Biopsy.
correct. Yeah, that's why we do dermoscopy, but we are not still sure, so we did a
Yes.
biopsy. The biopsy shows alopecia areata. When it was alopecia areata, she didn't want to anything. I said, why not to start local tofacitinib? And we started twice daily. And after 2 months, can you see this hair growth here?
Yes. Yes.
1 second. Yes, sir.
Yeah, but
Yes.
after 4 months, she has got very good hair growth because I was under assumption when there is an extensive lesion, the local treatment may not work.
Yes.
But then this patient has taught me local tofacitinib is also effective. So this is
So
the
she has applied only tofacitinib or any
yeah,
other?
no, nothing, only tofacitinib.
Only tofacitinib.
Only we corrected her hemoglobin, but from
Okay.
7.5 it came to 9,
Okay, sir.
not more than that.
Okay.
So topical tofacitinib in alopecia areata is, yeah. Now we'll divert little bit, huh? Dr. Kale, this patient of psoriasis, plaque psoriasis, put on tofacitinib. He came with this type of, he said, sir, I'm losing hair. Can you see this picture?
Yes. Yes.
Dr. Kale?
Yes.
Or
Yes,
Snehal?
sir.
Yes, sir. Yes, sir. Same.
Yeah, what do you think? Because he said, sir, I'm losing hair, probably because of tofacitinib. What do you think? What is this type of hair loss?
Androgenetic, sir.
Yeah. No, that is a patient's query. Of course, patient will come with their problem. But then at least we thought this is the male pattern hair loss. You agree?
Yeah, male
And
pattern looks
alopecia
like-
only.
Yeah. Yeah, male pattern hair loss. So then I said, this doesn't look like that.
Could it be
Then-
anagen effluent, sir?
Pardon?
Could it be anagen effluent?
Anagen.
Yeah, then, but he said, I'm losing the hair in these bunches like this.
So anagen effluent.
Yeah. So then, this you don't get this type of loss in the male pattern hair loss.
Yes.
Correct?
Yes, sir.
Then, of course, we went into detailed history and we found he had a COVID infection 2 months ago. So one of the common cause during the epidemics of COVID, of course, COVID history was very important.
Yes.
Yeah, so is a telogen effluent. Then we'll go for another patient. Can you see this patient? When this patient came to my clinic, we diagnosed psoriasis. We were thinking of whether we are dealing with the atopic, psoriasis, dermatitis. These are the common conditions. So when you see this lesion, Dr. Kale, what do you think in your clinic? Can you see that nail lesions at the base?
Yeah, even
Yeah.
that proximal nail fold is also involved.
Yes, correct.
Can you see pits are not there? Nail pitting, I am unable to see.
Yeah, there
Probably
was no
Sir,
other
proximal
lesions on the other part of the body.
psoriasis, localized nail
Looks like
psoriasis.
of nail.
Yeah,
Huh?
so yeah, we thought of localized psoriasis, maybe atopic. So we did a biopsy. Yeah. Oh, where it has disappeared somewhere? Yeah. We did a biopsy and see what we find in the biopsy. Biopsy shows up consisting with the nail psoriasis. So of course, then how we are going to manage this, Snehal?
So topical methotrexate, topical tofacitinib, cyclosporin.
Yeah. So we started with topical tofacitinib, and you see that if you look at the base, there is a very good improvement within a month.
Yes, sir.
And this patient came today. He came today for follow-up. Of course, he is not staying; he is abroad. But then there is a very good improvement. So these are the experiences we are sharing. Then this is another patient of lichen planus, 73-year-old patient. She had a hyperkeratotic plaques on the both extremities. She had used whatever the immunosuppressive drugs are available in our country for our clinical use. She was not improving. This is 4.5 years before I'm talking. This patient came to me. But as usual, we did a biopsy to rule out because she had a hypertrophic lichen planus for many years. And then it turned out to be pseudocarcinomatous hyperplasia. We started on tofacitinib, 5 milligram BD. Patient was happy, and you see everything clear. But after 4 months, she phoned and she sent a photograph. She said, Doctor Sahab, I'm getting this swelling, very painful, and unilateral swelling of the foot. So, Dr. Kale, what do you think? Because patient is on tofacitinib, she has got diabetes, hypertension, comorbidity, and she is 73 years old.
Sir, basically, even thromboembolic phenomena are also with high dose of steroid, this tofacitinib known. So I
Yes.
think some vascular problem, thromboembolic phenomenon must be
Should be,
there.
yeah. Should
That
be.
we have to rule out.
Thrombosis, deep
Yeah.
thrombosis, pulmonary embolism, known to cause such type of things.
Yes, correct. So I entirely agree with you. Before starting tofacitinib, we must rule out there is any thromboembolic phenomena or any evidence in the past. Patient is obese, patient has got varicosity, a DVT, everything we have to rule out.
Even if patient's history about if she is on OC pills and all, not for this patient, but
OCP.
for young patient, we have to ask about the if she is on OC pills or all.
Okay, so this patient, it is cellulitis, bacterial infection. So because it's very painful, yeah. So Snehal, how are you going to manage this patient?
Sir, first we have to stop tofacitinib.
Yes.
Then we have to, if there is any pus culture, then we have to send pus culture or blood culture.
Yeah, of course, there was no pus. There
then
was
blood
hardly any fever, so it was still localized.
Yes, sir.
So, yeah.
So first line of treatment, systemic augmentin should be started, sir.
Yes, correct.
In the form of tablet or IV.
Yeah, of course.
Blood culture comes positive according to the organism, we have to shift the antibiotics.
Yeah. So we gave her linezolidine 600 milligram BD,
Okay.
and see everything is clear. But the question is, are you going to as you said, in any active infection, you have to stop
You
tofacitinib.
have to stop
Any-
tofacitinib.
Yeah,
Yes, sir.
correct. Yeah. So we stop it, and now are you going to re-challenge it? Are you going to re-continue? What you are going to do, Dr. Kale?
Now the lesions are settled. I think
Yeah.
you are telling the now the lichen planus lesions are settled.
Yes, correct.
So we have to wait, and if the smaller lesions are coming, can we manage with again topical things? Because re-challenging
But the
only
lesions were very extensive. Yeah. It's a very,
and
very
can be
expensive.
after 1 or 2 months, after 6 weeks, can be started with low dose. 5
Yeah, you are
milligram.
absolutely right. After 2 weeks, we started with the low dose, and we are maintaining her on 5 milligram once in a week. Absolutely, yeah. So, what are the side effects? Of course, there are many side effects. One of them is what is called is a bone marrow, thrombocytopenia, anemia, general cytopenia. It's very important. That's why most of the patient, when we start with the higher doses, sharing my experience. Usually, I start in acute condition, 10 milligram BID. Hardly I start 10 milligram daily, 20 milligram, where you have to get monitor CBC every week till the doses are high. When doses become smaller doses or reduced doses, then you can do once in a month or once in a 2 months. So that is one of the common side effects I have come across. There are many side effects. Yeah, this is about the DVD we are talking about. The patient with the cardiac problem, myocardial, we know that malignancy. Okay. Yeah, this is the another patient. Dr. Prashant, you must tell me when I should stop, because there are so many cases.
We can start with questions, sir, because
Yeah, okay. Then we'll stop it here. And
yes,
because they are waiting. I entirely agree.
yeah,
Yeah, okay.
there are
So
many questions which have come. Very
I'll
interesting
stop
questions.
sharing. I'll stop sharing.
Okay, okay.
Yeah.
These few questions have come. I'll just ask.
Yeah.
Can we give tofacitinib along with statins?
Tofacitinib along with
Statins.
Statins.
yeah,
Statins.
statin. Yeah. Snehal.
What, sir?
Can be
Can-
given, sir.
Tofacitinib
Can be given.
can be given.
That is safe.
No.
There is no target.
Yeah, one second. Yeah, what she says right. But the question comes because the cyclosporine cannot given with the statin.
Yeah.
Yes,
Yeah, that's why they're asking this. Correct.
Exactly.
Yeah.
The next is, can tofacitinib be given along with steroids and other immunosuppressants? Can it be co-prescribed, in short?
Yes, it
Yeah.
can be co-prescribed.
Yeah, it can be given. Yes.
But
It can be.
try to avoid because the side effects are more. If
Okay.
possible, try to avoid because double combination gives more side
Immunosuppression, double
effect that is known.
immunosuppression will have, yes.
Yes, correct. That's right.
In which of the dermatologic cases tofacitinib works the best? I mean, amongst alopecia or psoriasis or atopic dermatitis, which is the best? I mean, in which condition tofacitinib works the best? In these three conditions.
Snehal.
Sir, mine's first is psoriasis, second is alopecia areata, and third is atopic dermatitis.
Dr. Kale, you agree
Mine
with
is
her?
alopecia, then atopic, and then vitiligo.
Psoriasis. Vitiligo.
Vitiligo also.
Yeah.
Yeah, in a vitiligo, I'll have a question. Snehal, I've got a question. One of
Okay,
the
sir.
patients, she is from Pune only. She had an extensive vitiligo. She is a daughter of one of my colleagues where I'm working, Bridge Candy Hospital. But then she had taken all treatment. Then he just approached, is there anything? I started on tofacitinib. And after 2 months, there was no improvement at all. So what do you think?
Sir, we have to stop tofacitinib.
Dr. Kale?
They say at least you have to give it 4 to 6 months, and you can escalate the dose. If there is no improvement, you can increase the dose. Few studies says even up to 12 months you give to see the results.
Few
But
studies.
generally, in our practice, I think 4 to 6 months are enough.
See, this was again 4 years before. and we were in the learning stage. I went to literature, and the literature says it takes at least 16 weeks to 20 weeks to show improvement.
Yes,
So
yes.
improvement will be seen after 4 to 5 months. But then I'm conducting this seminar across the country, and according to the dermatologists across the country, they say tofacitinib with UVB, narrow band UVB, it works very well. It's a combination of phototherapy and tofacitinib gives better result in vitiligo.
So topical I have tried in many patients.
Yeah.
Oral also tried, but oral works wonder. But I have always pro-prescribed with the oral mini pulse therapy when there is a generalized vitiligo.
Yeah, yeah. Yeah, but this across the country, they said you combine with the phototherapy, it works very well. But
Yes,
as
sir.
you said, everybody doesn't have phototherapy. Like
Yes.
me, I do not have phototherapy. The
Sir,
Bombay, we do not have this place.
difficult. In medical college, it's very nice.
Yeah, so I can combine that. Okay. Okay.
Okay, sir.
Yeah,
But
Prashant.
what is the duration, maximum duration for which tofacitinib has been given? And do we need to taper the dose?
I could not hear because of this Ganpati.
I also can't.
Yeah, I
I am
think you
also unable
answered.
to hear.
But the question is, for how long can we give tofacitinib, and do we need to taper the dose before stopping?
Okay, yeah. Okay, yeah. See, there are clinical trial, the tofacitinib, of course, from the rheumatology, is given 8 to 9 years.
Oh,
Yeah. And you can reduce as your clinical experience. Instead of 2 BD, you can make 3 tablets, then 2 tablets. And as I mentioned, you can make once in a week and you can continue for 2 years, 3 years. There is no harm. Only thing, you have to monitor CBC.
yes.
Yeah.
And what would be the management of relapse of cases of alopecia areata? Suppose if the patient relapses after on alopecia areata after stopping tofacitinib, how do we manage that?
I think Dr. Kale, you have to answer because you have shown your cases.
Yeah. Basically, relapse, if you stop abruptly, then it is going to relapse. As you told, once the good results are there, patient has to be on medication, some or other. You can make it alternate day, you can make it once in a week. And if recalcitrant patches are there, you can apply topical tofacitinib or topical tacrolimus or something like that. So abruptly stoppage, even my 2 patients, once they got good hair growth after 5 to 6 months, they have stopped. They thought there is no point in going again and again to doctor. And they came after 3-4 months. Not at a few patches they developed, the 8-10. Again, I have started the treatment.
So we have to maintain therapy for the prolonged period.
Yes.
And you can either reduce the dose or you can go for the alternative drug like methotrexate, correct?
Correct.
Yes.
Okay, yeah.
Should routine testing be done before starting tofacitinib?
Yes. Yes, it is needed.
It is
Before
needed.
starting tofacitinib, you have to do all panel what is given for tofacitinib,
Including TB test.
Yes, that is very important.
including IGRA. If IGRA
Yeah.
patient
Yes,
is not afforded
exactly.
for IGRA, then simple chest X-ray and
Chest
Montu
X-ray.
carried out.
My 2 patients were positive, so latent tuberculosis is very common.
Yeah.
IGRA
Prashant, this is
yeah.
very important. Can you repeat this question little bit loudly?
The question is, before starting with tofacitinib, should all tests or should all precautions be done? I mean, in the sense of laboratory tests and other tests.
Yeah, this is a very important question. See, before starting, you have to rule out any underlying active infection. On our country being endemic for tuberculosis, we have to rule out underlying tuberculosis. Any active tuberculosis, because there will be loss of weight, fever. But what is important is latent tuberculosis.
Latent.
And to rule out
Correct.
latent tuberculosis, there is a lot of confusion. Many specialists, they say you have to do IGRA and Montu test. IGRA is a must, but I can tell you, either you do IGRA or you do Montu, both tests are not required. According to CDC recommendation, they do IGRA in America, you will be surprised. IGRA is very cheap in America because they have to come only once. Because Montu test, they have to come 2 days. When they come 2 days, it becomes very expensive. So they
Correct.
do IGRA tests. So both the tests are not required. Along with ESR, chest X-ray, either you do Montu test or IGRA. I can tell you all my 500 cases, I never did IGRA in my
Okay.
clinical practice. So one test is enough. Secondly, there are 2 studies where the studies they found one, of course, is from rheumatology meta-analysis. 4 patients who are on tofacitinib, they develop tuberculosis. But that study, what they have done, they look only for the active tuberculosis.
Correct.
They never look for latent tuberculosis.
Latent.
So always you have to look for latent tuberculosis.
Latent.
This is the message. Yeah.
This is last question.
So,
Does
sir,
tofacitinib, yes.
so X-ray chest and Montauk is sufficient. You want to see say?
Yeah, X-ray chest, Montu test, and ESR.
ESR.
These 3 are
Yeah,
enough.
yes, sir.
Yeah.
So there is no need to do
If-
IGRA.
Again, I'm
Because-
repeating either IGRA or Montu. No need of doing both the tests.
Because Montauk false positivity is
So
more.
if a patient wants to get it done, you can get it done. There is no harm.
Sir, affording capacity of the patient is only problem while getting it done. IGRA for every tofacitinib patient.
Yeah, that is costly test, but nowadays even pharma companies are giving some coupons and all for taste, I think.
Okay, sir.
Yeah, okay, that is everybody.
Then there will be no problem. Their pocket will be the problem, patient's pocket.
Okay. But no
Last
need
one.
of doing IGRA. Again, I'm repeating because
Okay, okay, sir. Thank you.
everybody
Okay,
keep
sir.
on confusing, and unfortunately, our dermatology they follow other faculties. And as a HIV clinician, I can tell you, I
Yes,
see 3 to 4 patients of tuberculosis even today, every day. So about TB, you ask me any question, there is no problem. Okay.
Sir, if
Those-
IGRA comes positive, I want to ask sir one question. If
Yeah.
IGRA is positive, then
Yeah.
we have to give TB prophylaxis for the patient, and after that
Correct,
we have to
correct.
start
See,
tofacitinib.
IGRA or Montu test come positive, Montu test strongly, you have to give prophylaxis. IGRA positive, you have to give prophylaxis. Prophylaxis given Isonex 300 milligram for 6 to 9 months. If
Yes,
you do not want to give, we can give Isonex and rifampicin combination for 3 to 4 months.
3 to 4
And
months.
before starting, you have to give Isonex at least 1 month. That is according to the recommendation. But I don't wait for anything. I start Isonex and tofacitinib together.
Okay, sir.
Yes, Isonex and Tofa, there is no contraindication, but
No,
should
no,
not
you
start
can-
with Arsin, I think.
Partner, sir, if IGRA comes positive, giving it with tuberculosis prophylaxis, tofacitinib should not be prescribed, no?
Who said? Who said?
We can prescribe tofacitinib along
Yes,
with,
yes,
Yes,
100%.
yes. But
With Isonex prophylaxis.
with
but
ice.
not with Arsin, I think, sir. Not with
Yeah.
Arsin because again it acts with 450.
Yes, correct.
With INH?
Yeah,
see-
with the rifampicin and tofacitinib has got drug-drug interaction.
Yes, sir.
Rifampicin is the inducer, you know,
Hmm.
enzyme inducer. Better
Yes,
not
sir.
to give with tofacitinib. Yes, correct.
Yes.
Last one, sir. Does tofacitinib increase the risk of stroke?
Risk of?
Stroke,
Stroke.
cardiovascular diseases.
Yes, sir. Cardiovascular.
Yes.
Hypertension, stroke.
It is more commonly associated with pulmonary embolism and deep vein thrombosis like DVT. Rather
DVT.
than stroke. Stroke is again
Okay.
because of embolism only. Patient can get acute CV
Yeah,
attack.
out of embolism, anyone can.
Embolism and yes, it is associated.
Yeah, Prashant, there are studies. They say the risk is as good as with patients who are not on tofacitinib. That is the
Yeah.
study says, but we have to be careful.
Careful. Yeah, if it
With the history of cardiac problem,
yes, yes, and
better to
embolism.
avoid. You
Yes,
can
sir.
have other option, better
Yes,
not to
yes.
give it. Yeah.
So thank you very much. It was a lovely session, this question answers and your case studies. I mean, it's a very informative. Thank you, all of you. Thanks, Dr. Saple. Thanks, Dr. Kare. Thanks, madam, for this lovely
Thanks.
session. I thanks
Yeah.
the marketing team of Hitro for organizing this, sales team for conducting, and most important, IT team for a continuous support. Thank you very much, sir. And thanks, Dr. Kale, and thanks, madam. Lovely insights on
Prashant,
capacity.
1 second. I must thank you for Dr. Kale for
Yes,
your real good inputs,
yes,
And of
yes,
course,
yes.
Snail also, both of you are wonderful.
Thank
It
you,
was
sir.
really, I was very happy you were asking me questions,
Yes, sir.
Because
Yes, sir.
usually moderator people do not ask question and you were asking, I was very happy. This is how we have to discuss,
Yes,
That's
sir.
how the message, and so I must thank you,
Yes.
all those people who are attended, Dr. Prashant, Dr. Manohar, and their team, and of course, technical person, Mr. Giridhar. Thank you very much.
Thank
And
you,
Last
sir.
but not the
Thank
least,
you, sir.
we
last
can
but
leave
not
for
the least,
dinner,
thanks,
no?
thanks, thanks all the doctors who took time to participate in this webinar. Thank you very much. Signing off for the session. Thank you.
Thank you, Saple sir, on behalf of Teachers Day.
Thank you, sir.
Your teaching and your motivation inspires us a lot.